Welcome back to Hot Flashes and Cool Topics. Today we have on Dr. Jewel Kling, who, as we mentioned in the bio, is an associate professor of medicine. She works at the Mayo Clinic. We are just so excited to talk to you about hormone therapy today. Welcome to the show.
Thank you so much for having me. And thanks to you both for creating this platform to talk about, topics that many women don't talk about and destigmatizing things like menopause and hormone therapy. I'm really excited to be here.
Well, we appreciate your time. We know you're extremely busy, but we want to get the word out for women that there's options and you don't have to be afraid necessarily of HRTs just because you've heard about all this stuff from the early 2000s. And it's just such an important conversation and we appreciate you taking the time to talk to us. So there were a couple of things there's so many things I wanted to talk to you about, but with menopause hormone therapy, I know you talk about early use of hormone therapy and later use. Can we start a little bit? I don't think we talk enough about postmenopausal women. And how does hormone therapy play a role for postmenopausal women?
Yeah, well, and maybe we can start just briefly with some definitions, and you may be aware of these and your listeners may be as well, but even, we did a study looking at residents' knowledge of these. Some of the basics aren't taught very often, so that can be helpful. We define menopause clinically as 12 months past the last menstrual cycle. Although hormones can be suggestive of menopause or perimenopause, that definition really relies on when the last menstrual cycle stopped. The average age of menopause in the US is about 51 years of age. And so when we're talking about like normal menopause or postmenopause, that's really that group of women that we're talking about. And our most recent guidelines, based on evaluation of the previous kind of sub-analysis of the Women's Health Initiative, but other studies too, shows that for women less than age 60 or within 10 years from their last menstrual cycle, that the benefits of hormone therapy largely outweigh the risks. Now, the other group of women that is really important to talk about, hormone replacement therapy, which I'm calling it a little bit differently there. I think you did that too really appropriately, that menopausal hormone therapy is when we're treating symptoms of menopause in that kind of natural menopause or normal menopause area. But for women that have early or premature menopause, so menopause less than 45 is considered early and before 40 is considered premature. Those women really need hormone replacement therapy until the normal age of menopause or the average age of menopause, 51 years of age, to help prevent a lot of long-term health consequences like Alzheimer's disease, Parkinsonism, cardiovascular disease, osteoporosis, sexual dysfunction. And that's not just for treating symptoms like hot flashes and night sweats, it's really to prevent those kind of long-term consequences.
And women in that case, are these women that maybe would have had to have a hysterectomy or surgical menopause or any other cause like that?
Yeah, no, that's an excellent question. And that is a big group of women that I see in my practice, are those women that have, say, for example, really, really significant endometriosis, and they're kind of debilitated by their endometriosis. So make the decision with their, gynecologist to pursue a hysterectomy and have their ovaries removed. And if they do that before 45, yeah, those women do need hormone replacement therapy. There are other causes of early menopause, something called premature ovarian insufficiency, which can be caused by various other things. And if any of your listeners are hearing and they're like, oh my gosh, I haven't had a period in this amount of time, I'd encourage you to go talk to your doctor, because there's other testing and things that we would just need to make sure are not contributing to your early menopause, as well as getting on hormone replacement therapy,
And that made me think of a question. When women start going through even natural menopause and they have suffered from endometriosis for most of their life, does that get exacerbated during menopause? Is it a factor?
That's a great question. Typically, it's thought to be the opposite, that because endometriosis tends to be a hormonally driven process, that as women enter into menopause, many times their symptoms improve.
That is good to know. That's
We
very
always-
interesting. Yes. Yeah.
You got to celebrate the positive things too, right? When you're going through the change, going through menopause, and then, acknowledge the negatives or the opportunities for treatment.
Do you also find, and this is a personal question for me because I've now not had a period for 3 months, yay, woohoo, woohoo. But I've noticed that the symptoms were a lot worse before I stopped getting my periods. Like my symptoms seem to be a little better over the
I'll
last
have
3
to
months,
agree
like
with that. Yeah.
migraines and mood swings and things. Is that normal?
That's a tough question. What is normal? For
Right,
each woman,
true.
it's going to be different. But I think, what you're bringing up is this idea that during perimenopause, you can certainly have all the symptoms that we classically think of during menopause. And I think, many of us women, and maybe I'll just speak for myself, I don't know, you go through your childbearing years, you're like in your late 30s, you're busy with your work and your kids, and then you enter your 40s. And it's not on your radar that, gosh, menopause is right around the corner. And it's not atypical to start having perimenopausal symptoms like in your early to mid 40s, oftentimes like heavier periods, lighter periods, but it can be what you're talking about: hot flashes, night sweats, irritability, sleep issues. And for some women, it's those during those perimenopausal times that it is much rougher. And it may be because, when we look at the hormones and what they're doing during that perimenopause period, it is like a roller coaster. One day can be like this, the other day can be like that. And so you're feeling those large swings in hormones. And then postmenopausal, so once you've, finished really having a period, your hormones stabilize. And so I wonder if that's what you're feeling, is instead of having these swings, now they're stabilized. You may still have hot flashes, night sweats, vaginal dryness, sleep issues, but it's not like changing from day to day.
And then you're probably feeling just a little bit better,
Right.
because
Sure.
things aren't just going all over the place.
Yeah.
Yeah. And I found it really interesting. I think when I was reading over some of your notes, you're probably one of the first people I've seen notes on that really talk about what to do or how many years to be on menopause. And
Hormone therapy.
menopause hormone therapy. Like I was, because I am on menopause hormone therapy and
Okay.
I'm 54 and I think
Yeah.
I've been on it about 4 years. So that was can you talk a little bit about what you find and how long through the studies that
Yeah.
you've done that have been done or recommended?
Yeah, no, it's a really important question and a challenging question to answer, because although we have more clarity now about the safety of hormone therapy when it's initiated early in menopause, we just don't have as much research to help guide us on how long women need to continue hormone therapy. What complicates the picture too is that more recent data or research shows that on average, the symptoms of menopause last for like 7.5 to 10 years. And I always make sure to say to my patients, like, I'm not sharing that with you to bum you out, because that's a long time. But if anything, to raise the importance of us talking about a treatment plan, because toughing something out for 7 to 10 years is just not okay. But that would mean, so if you're going through menopause at 51 and it's on average 7 to 10 years, which could include those perimenopausal years too, that towards your late 50s is when you would be expected to not have symptoms. And so typically, as my patients approach 50, I'll start talking about a plan to taper down on the hormone therapy. And if you come off the hormone therapy and you're not having symptoms, then you don't need to continue it. But if you continue to have symptoms, then it would make sense to continue it and just on an annual basis talk about, risk benefit. And so what that looks like is, say you had something happen like a blood clot, it may mean that you have to consider something else, like coming off or transitioning to something non-hormonal, or an abnormal mammogram, something like that may factor into that decision. But if you're staying healthy and you're exercising and eating well, if you need to continue the hormone therapy, then that can be a decision you make with your physician.
Question that I have is that we have several listeners who email us and say, I went to the doctor, I'm starting to have symptoms of perimenopause, and they handed me an anxiety medication, an
Mm-hmm.
antidepressant. And a lot of them are like, that's not what I want to take. I want
Yeah.
to help my symptoms. Why is it that a lot of women get handed an anxiety medication or an antidepressant for their first noted symptoms?
Yeah, I'm so glad you asked that question, because putting myself in that patient's shoes, would think, oh, they just think I'm anxious or it's all in my head, right? Where I don't think that's the intention, although I can't talk about the intention for all physicians or healthcare professionals. But what I suspect is going on is that we have good evidence that shows that SSRIs, or selective serotonin reuptake inhibitors, also called antidepressants, are beneficial at treating hot flashes and night sweats and can treat some of those other menopausal symptoms. In fact, we have an FDA approved antidepressant called paroxetine. The brand brand name's Brisdell when we use it for menopausal symptoms. And there's other SSRIs and other antidepressants that have been studied in this realm too. And so my suspicion is that healthcare professionals are still nervous about prescribing menopausal hormone therapy, which I want to make sure and say that it's the most effective treatment for hot flashes and night sweats. It's the best treatment that we can use for hot flashes and night sweats. So if we're looking for the best, yes, hormone therapy, if it's safe for that patient, should be offered. But because of a fear, because of myths, because of lack of education, may reach for that antidepressant, maybe because they're more familiar with it. And now they know, hey, this is FDA approved for hot flashes and night sweats. Here you go, take this medication. And that survey I was telling you about where we looked at family medicine, internal medicine, OB-GYN residents at 22 different centers across the US. In fact, we found a big percentage of training physicians would offer an antidepressant first for healthy women without contraindications that had hot flashes and night sweats. So I think that's probably what those women are experiencing.
That describes what happened to me exactly.
Oh, really?
Yes, when I went in, when I was experiencing hot flashes, really, really bad, like 5 times an hour, just drenched everything. And I was about 47 at the time. And I was offered I guess it was Effexor, or maybe the generic
Yeah.
form of Effexor. And
Venlafaxine. Yeah.
yeah, it really wasn't doing much. And
Mm.
finally, I did do the hormone. And I
Hormone.
believe they started with progesterone because I was still having cycles.
Oh, okay.
And I don't know if that's something normal that they do. And then when I stopped having cycles, then they did the estrogen, progesterone. I didn't know if that was something normal.
Well, maybe it was the other way around, that they started you on estrogen and didn't add the progesterone because you were still cycling, because the progesterone's used to prevent endometrial cancer. Anytime we give estrogen without progesterone, there's a risk of the lining of the uterus building up and, becoming cancer, if you will. So the progesterone counteracts that. But if you're still menstruating, like you're still perimenopausal, you may be having a bleed, sloughing your endometrium. So you may not need the progesterone.
Okay. I can't, it's been a few years, but
Yeah,
I
no
do
worries.
know my last visit, she said, you've got to make sure. And I do. You take that progesterone.
Yeah.
And she did tell me about the cancer risks.
Yeah,
You've got
it
to
is
take the
important.
progesterone. Yes.
What about for women who have Alzheimer's in their family?
That's an excellent question too. And I think I can answer that pretty easily. But do you mind if I just say something real quickly
Sure.
about the SSRIs or the antidepressants? I just want to take the opportunity to not minimize those treatments and their availability, because there are a lot of women that can't take menopausal hormone therapy, breast cancer survivors. I just saw a patient this week who'd recently had a stroke. And so it is really beneficial that we have treatment options that do effectively reduce hot flashes and night sweats. So just wanted to put that point out there too. But your question about Alzheimer's is a great one. The Women's Health Initiative, with that big study back in the 1990s, early 2000s that shut early, found that women that were older that started hormone therapy had an increased risk of Alzheimer's. Now, that information has kind of permeated media and everything. And so I think a lot of women are concerned, if I start hormone therapy, I'm going to get Alzheimer's. But there have been studies since that time that show if women start hormone therapy early in menopause, that it doesn't appear to negatively impact cognition. And we don't see those same kind of relationships. In fact, there's some kind of promising data that suggests there may be some benefit, meaning starting hormone therapy early in menopause, meaning under age 60 or within 10 years from the last menstrual cycle, may be preventative. Now, we don't have enough data to say that, women should start it to prevent Alzheimer's, but again, it's very, I think, reassuring.
Definitely. Okay, thank you for that. And what about women who have some cardiovascular issues, either family history or have existing, high blood pressure or other issues?
Yeah, and really, when we look at the statistics, most of us women have some, chronic condition like hypertension or elevated cholesterol. And so the reality is we do need to know how those interact with hormone therapy. And it depends. Each woman is going to need like an individual evaluation to see what that means for her risk or her health. If somebody's had a heart attack, probably you're going to be talking about a non-hormonal option. But say somebody comes in early in menopause, hot flashes and night sweats with hypertension or high blood pressure, There's formulations of hormone therapy that appear safe and don't impact the blood pressure, like a transdermal or kind of non-oral estrogen. If anything, that may benefit her blood pressure, because I'm sure the hot flashes and night sweats, if she's experiencing what you were experiencing, Bridget, like 5 times an hour, has got to be contributing negatively to her blood pressure. Many times what we'll do is do like an assessment of cardiovascular risk. So get a cholesterol panel, maybe get another study like a CT to look at the coronary arteries. And if those look well, then the risk is low and women can consider hormone therapy. But really it's an individualized evaluation for each person.
When a woman comes in, and it is so personal for every woman, if they
Mhm.
go to their doctor and they don't feel like they're being heard or seen, what would you suggest they do next? Go on to the North American Menopause Society, or what options they have?
Yeah, I mean, I think would be a great option. The North American Menopause Society certified practitioners all have a really good understanding of the current science and data and understand those implications. And so the NAMS has a really easy way to search for physicians or advanced practitioners in their community. Gosh, it's challenging because you want them to be able to maintain that relationship with their existing physician or APP. And maybe even the first step is sharing some of that information, like, hey, I listened to this podcast, or, here's some information from the North American Menopause Society website. Love for you to look at it. But I know that's challenging with the kind of hierarchical relationship sometimes you feel with your physician or APP. So the NAMS provider is a great option too.
That's so good to know, because we get so many questions and comments from women in those situations where they feel like they are not being heard, or even where a doctor will absolutely refuse to prescribe any kind of a hormone. It won't really do the testing that's necessary for it. I mean, I've heard
Mhm.
women from that, and it's really surprising, but it's great to know that you can go to NAM's website and
Yeah.
look for that in your area. That is
Yeah.
fantastic.
And what's, there's a lot of really crummy things that have come out of COVID or us living through a COVID pandemic, but there have been some positives. And one of those that we've found in our practice that we've implemented regularly is the virtual visit. So even, if women don't have access to somebody in their community, say they live in a rural area or, some place that just doesn't have menopause practitioners, considering a virtual visit with one of the NAMS providers would be an option too.
Yeah, if you were able to do that, and I'm not sure how this works, if they need a blood work, can you arrange to go
Hmm.
to a lab and have
Hmm.
that
Hmm.
sent to that? That's
Yeah.
great. Yeah.
In my opinion, I think what works best is collaborating with that person's primary care physician. So, and it is a teaching opportunity, right? Like we've already talked about that many of us don't learn about menopause in training. That's what our study showed too. So if I could collaborate with somebody's primary care physician and share some of these resources, and then perhaps they're able to take over that prescription or talk about labs, do the exam, those type of things, then you're, killing two birds with one stone, helping that woman get the care that she needs, but also maybe helping future by providing some education.
Right.
Absolutely.
Mhm.
Can you explain a little bit about the difference between hormone therapy and bioidentical therapy?
Yeah, absolutely. Bioidentical just means that the hormone looks like the same hormone our body makes. So estradiol is 17 beta estradiol. That's the estrogen that the ovaries make. And really, it's been used mostly as a marketing term post Women's Health Initiative to support the use of like the custom compounded bioidentical therapies, and been labeled as a safer option compared to the traditional hormones that we use, when in reality, we have FDA approved bioidentical hormones and they're all similar. So the safety profile is similar. Just because you do something that's custom compounded doesn't mean it doesn't come with risks, and kind of vice versa. Does that
I
make
didn't realize
sense?
the
Yeah.
bioidenticals were FDA approved.
Yeah.
I felt like I've been
Some
told a lot,
are,
and some,
is it
okay.
that some are and some are not?
Yep. Yeah, absolutely. So they're like estradiol is an FDA approved hormone that we have in FDA approved formulations like a transdermal patch, pill, a vaginal ring, a spray, and a gel. But then there's some hormones like estrone that's not FDA approved, but that may be, compounded in something like Biest or Triest in a custom compound in pharmacy. There was a kind of update that came out recently from the National Science Academy that looked at the safety of the custom compounded bioidentical therapies and found that there's just not enough research that supports those, both the safety and the efficacy. And so it's in, I think, most women's best interest to do an FDA approved bioidentical therapy if that's what they're interested in.
That's good to know, because I think we and many people thought that bioidenticals were just compound and not
FDA approved.
even
Yeah.
reviewed
Yeah.
by the FDA. So it's good to know
Yeah.
that there are options like that. A lot of times estrogen is recommended in patches or creams. What is the problem with oral estrogen?
Yeah, I guess there's nothing necessarily wrong with oral. It's just that when hormones are taken orally, they get processed through the liver first, which is called the first pass hepatic effect. And that can lead to kind of more clotting factors and things like that. So if you do the transdermal or the non-oral route, then you bypass that and it's associated with less of those risks. So if somebody has things that may put them at higher risk for blood clot, say they're obese or they are a smoker or they have a family history of blood clot, doing like a lower dose transdermal estrogen would be safer in that context. The other thing to your question earlier, Bridget, the kind of duration of treatment, if I think a woman may need hormone therapy longer, or she's, considering that starting with a transdermal or non-oral route means that, as you approach your late 50s, early 60s, you're going to be on the safer formulation that you could probably continue if needed.
It's very good to know. And I know you mentioned too, if you decide to go off, is it something that you need to do gradually, or do you just stop doing it? What should be done when you
Yeah.
decide to go off of them?
You can do either. The studies that looked at both ways didn't show much difference, but most of the time I'll recommend a taper with my patients. I think it's just easier to, even just to get on board and to slowly wean off and see how things go as opposed to just stopping at cold turkey.
Have you noticed changes in the conversation with your patients over the last few years? Do women seem to be more educated about menopause, or are they still, there's so many of us, especially in our generation, that didn't even realize we were in perimenopause and then had an aha moment years later. But are you noticing a conversation change, or is it still kind of behind the times?
That's a great question. And I don't know, I think we still have a lot of opportunities for improvement in education. Yeah. And to be honest, I find one of the most exciting and fulfilling parts of my job is being able to answer that question for somebody that comes in thinking, hey, I can't take hormones because my mom had breast cancer at age 80. Like, well, actually, you can. So although that's great that I can share that information with them, I think it highlights your point that there's still a lot of misinformation out there that hopefully through amazing podcasts like what you both are doing, we'll get the word out there so women know what resources they have available to them.
I think that's so true. I did not realize I didn't know what perimenopause was when I was in perimenopause.
Right.
I didn't know what that word was. I was already in it when I realized what it was. And
Yeah.
also there's so much I did not know before we started this podcast
Oh,
that I have learned in the past 2
Oh,
years
wow.
by talking to people like you.
That's great.
And I'm still learning. Like I'm
right.
learning
We
from
learn
you
every
today.
time we talk to someone.
Yes. Yeah.
Another interesting thing is all of a sudden now on social media, on commercials, you are seeing all these products that say they can treat hot flashes and cool topics naturally. It's over the counter. It's a, amazing tea you can take. It's all these things. Women kind of overwhelmed all of a sudden when they come in. Do you say to them, like, what do you say to them? Try it first or don't listen?
Well, yeah, and I think it just demonstrates that women are desperate for something to help with their symptoms and want to do something that they feel safe. And I don't know, something about how it's presented just makes it sound, well, it's over the counter, it's got to be safe, right? And I don't know if that's always the case. But what I can tell you is when we look at the research, that there's not really many, if any, over the counter supplements that are effective or really better than placebo at improving hot flashes and night sweats. So many of the medications like black cohosh and things like that have been studied. And while they do improve hot flashes and night sweats, they don't do so more so than taking a placebo pill. And so if a patient's taking it and noticing improvement and they're not having any side effects from it and they can afford the medication, oftentimes I won't have them stop it, but I will let them know that there's more effective treatments that are also safe for them to consider.
With the is it Cohosh? I want to make sure.
I'm not sure it's Cohosh or Cohosh. Yeah. Yeah.
We've heard good and bad things about that there aren't enough tests out there yet to see if it actually can affect, because there are some supplements that can have a negative effect on your body. And women, like you said, they're so desperate for relief.
Yeah. No, it'd be great to have more research in that area, but the research that we do have, like I said, doesn't demonstrate the effectiveness. There is also some risks, particularly to the liver and things with that supplement. So if anything, if a woman's considering starting something like that, make sure they talk to their doctor to make sure it doesn't interact with another medication that they're on, or, cause something based on their underlying health conditions. But really, maybe that opens the opportunity to find that menopause practitioner that can talk to them about truly effective treatment so that they can get relief from the symptoms that they're having.
And like you said, there's telehealth now out there.
Yeah.
Have the conversations, and we've worked with some companies that do it, and they're really just trying to get the word out.
Yeah. I guess one kind of cautionary tale about the telehealth is making sure that it's a reliable kind of institution or physician that you're seeing, because if it is backed by some product that it's all about profit and you're not having the proper safety evaluation that you need, then that can be potentially, worrisome. So if it's an institution like Mayo, we offer virtual visits. If we deem that you need to have a physical exam, we'll certainly set that up or make sure your primary care does that, because oftentimes things like a physical exam are important when we're doing evaluation of like cardiovascular risk and things like that. So
is there any type of accreditation that people should look for when they're looking for online health? I didn't,
That's a great question. Yeah. I mean, I think making sure that the physician or the, practitioner that you're seeing is a certified or, board certified clinician would be important. I suspect that we're going to see more of that happening, right? That there's going to be licensing or whatnot if it's a truly only virtual platform. But maybe for the time being, going somewhere that has a clinic, like a physical clinic too, so you have those resources, meaning if you needed to come in for an exam, that's available too.
Another thing that I was really excited to read about when I was researching your work is the conversation opening up about transgender hormones, and how, because that is something that now we need to factor into hormone therapy. What, opening up that conversation, like what are the concerns for transgender individuals taking estrogen or testosterone?
Yeah. Well, probably the important place to start, and maybe I'll just briefly, in case some of your listeners aren't familiar with transgender care, transgender people, transgender people are people that are born with their sex assigned at birth or recorded at birth that's not congruent with their gender identity. And when we look at the components that make up who we are, gender identity is the most important for defining what our gender is. And so you simply have to ask somebody, they know what their gender identity is. So a transgender, like a transgender man or male, would be somebody that was born as a female assigned at birth and now identifies as a male. The kind of clinical diagnosis or definition is something called gender dysphoria, which means like being kind of upset or dysphoric about that incongruence between your sex assigned at birth and your gender identity. And the goal for treatment is to relieve that dysphoria. Not all transgender people are dysphoric. Some are just fine. And not all transgender people seek treatment beyond kind of identifying or kind of expressing themselves as the identity that they feel that they are. But for those that have dysphoria and want to seek gender affirming hormone therapy, you're right, it's important to evaluate those risks associated. So for a transgender male, they'll be doing a masculizing hormone like testosterone, and a transgender woman or female would be on a feminizing hormone like estrogen. So similar to what we do for all of our patients on hormone therapy, looking at risk factors like cardiovascular disease, blood clot, those type of things. But maybe similar to menopausal hormone therapy, across the board, gender affirming hormone therapy appears safe. And more than that, it's truly life-saving for somebody that experiences gender dysphoria, because the amount of depression, anxiety, suicidal ideation, just all of the complexities that are rooted really in the discrimination and kind of social pressure. So I want to make sure it's clear that transgender people aren't innately depressed and anxious. There's a lot that goes into that, and a lot that is really caused by our society and us in healthcare, discrimination, those type of things. But that degree of dysphoria can be debilitating to somebody, and providing gender affirming hormone therapy is life changing. So that kind of trumps the risk benefit ratio when we're talking about it, and you're going to do what you can to be able to get that person the treatment that they need.
Do you find that a certain age is better if this is something they discover they want to do? And I know this is very individualized.
Yeah.
Is it better to start the process with the younger the better, or is it okay when you're older and this is something you've always felt and you wanted to do, and now you've come to a time in your life where you're like, okay, I can do this?
Yeah.
Is there a certain age that's better to do that?
Yeah, I think you hit the nail on the head at the beginning, that it's going to be really individualized. And because of all those stressors and pressures and whatnot, a person acknowledging the time that makes sense for them, because they'll need support, and they'll, social support and all of those type of things. And so again, it's going to be when they feel ready.
With a transgender female to male who's been on testosterone, they still
Hmm.
have uterus, they still have ovaries. Can they
Hmm.
expect anything around that menopausal age? Will they go through
Hmm.
any symptoms?
Yeah, they could. Yeah, absolutely. And during perimenopause, especially if you're on high doses of testosterone, that could cause some more abnormal bleeding or kind of unanticipated bleeding. So, as healthcare practitioners, it's important to ask about those things and provide either a progestin or some type of treatment that's going to help with the bleeding. But for the hot flashes, night sweats, or other symptoms, there are some treatments. It does get challenging because you're not going to give them estrogen if they're on testosterone, but it may be kind of a combination of things that you try.
So good to know. I feel like we've talked about so many things.
Yes,
Thank
yeah.
you for being so flexible. We're like jumping from
Here
here
it
to
is.
here.
Yeah, no, I
Yes.
love it. This is
Yeah.
great.
But
Such
I think
important.
it's so
Yeah.
important, yeah, for people to hear this.
With women who are kind of having that aha moment and they're saying, I think I'm starting menopause, what would you suggest can they go on the North American Menopause Society website and kind of start doing their own research? Where would be the
Yeah.
first place you would suggest they go?
I think that's a good place to start, because if you just Googled it, there's so much out there. Some of it's really reliable and helpful, and some of it's misleading. And I think fueled by an industry that, filled a need post Women's Health Initiative. Women needed treatment and they filled that need, but now may be driven by things like profit. And so I just, I'd want to make sure that women are getting evidence-based, really helpful information, and the North American Menopause Society is going to be a great place to start.
And I think I have one more question.
Oh,
You
sure.
probably have a lot
Yeah.
more, but with women, we have a lot of listeners that are post-menopausal and they're like
Mhm.
been there, lived through it to
Mhm.
tell the tale, but they're still having like kind of a hot flash now and again, or they're having trouble sleeping. A lot of them have insomnia.
Mhm.
What would you suggest for them that they maybe not want to go on hormone therapy because they're pretty much post-menopausal?
Yeah.
Can you suggest anything for them?
Yeah, absolutely. And there are a lot of things, after you've completed or gone through the menopause transition that continue. Sleep can be an issue. Vaginal dryness and pain with intercourse are extremely common. So talking with their healthcare practitioner about treatment options like a low dose vaginal estrogen, which doesn't carry the same risks as systemic hormone therapy and can be continued really indefinitely. Sleep is so important. We've done some studies looking at the association of sleep and sexual functioning. I say that out loud and I'm like, yeah, of course that makes sense. If I'm tired, I'm not going to be interested in sex, but we've been able to show in studies that there is a link there. So if women are noticing sexual issues and sleep issues, they need to really address both of those. And one of the things we've seen is that kind of historically, really across the board in medicine, we've not done a good job of studying women in particular. Really, up until 1990, most studies were done almost exclusively on men or male animals or, basic science studies like that, and extrapolated to women, which means the presentation, the treatment, the evaluation of certain things like sleep disorders may be skewed to studies in men. Specifically, like, for example, sleep apnea. I wonder if you both have heard of sleep apnea. It's a pretty common thing, but we see in women, they tend to have insomnia and daytime fatigue and may not have the other kind of classic symptoms of sleep apnea. And we're probably not screening and finding that enough to be able to treat them. And so I guess that long-winded response is make sure you get in to talk to your healthcare practitioner if you're having sleep issues, to see if there's something maybe underlying that's going on, but that they can give you some tools to help out with that.
And you brought up vaginal dryness, low
Yeah.
libido, and I know, and I want CVD. Oh no, not CVD. The what?
Janet.
I'm gonna have you
GSM.
say it.
Yeah. The
Yes.
genitourinary syndrome of menopause. It's a mouthful, isn't it? Yeah.
Yes.
GSM.
Yes.
Yeah.
Can you talk a little bit about that and
Yeah.
what that involves? Yes.
Absolutely. And I'm so glad we're talking about this, because this is another one of those areas that I think, like, where do we talk about it? Where have we seen it in the media or whatever? I don't know. Like, how do women learn about this? And I think what I've seen a lot is that I think women just think vaginal dryness and pain with intercourse is par for the course. Like, that's what happens when you get older, and just live with it. When in the reality, you don't have to live with it. And some don't even connect it with menopause, because oftentimes those changes don't happen until a couple of years after you've gone through menopause. And so think it's something else or just aging or whatnot. So we can see it like 2 to 3 years after that final menstrual period. But it not only causes vaginal dryness and pain with intercourse, which, I mean, those are super important and need to be addressed, but it can also cause urinary urgency, like feeling like you have to pee all the time, as well as increase your risk of urinary tract infection. So for those women that are listening and they're like, oh my gosh, yeah, I'm postmenopausal and I've had 3 urinary tract infections this last year, vaginal estrogen may be the best option for you after, an exam and discussion with your physician. But there's a lot of different vaginal estrogen products. There's even a vaginal kind of androgen. It's DHEA. It's more similar to testosterone. It's called Interosa. That's really effective at treating those symptoms too. So I encourage women to consider doing those. And important point, you should never have pain with intercourse. So if you're having pain, something's going on, and get evaluated for it.
So you said Interosa, is that a prescription?
Yep.
It is a prescription.
Yeah.
Okay.
Yeah. And I guess to your point, all of the things I spoke about, the vaginal estrogens and the vaginal DHEA are prescriptions, but there are over-the-counter treatments that women can use. Lubricants are what you would use with intercourse, both on you and your partner. But then vaginal moisturizers are developed or have been developed for women to use regularly. So like a facial moisturizer every couple of days. And that can be over the counter. It's non-hormonal. And for mild symptoms, that works great for symptoms.
Yeah, I'm so glad you brought up the part about the urinary tract infections, because
Mhm.
someone I know in their 70s, their doctor started to experience UTIs.
Yeah.
And the doctor said, "You need a
Yeah.
vaginal cream." And her response, "Well, I'm not having sex. I don't need a vaginal cream." So
Yeah.
I will tell her, "Yes, you do." Yeah.
And that's why they renamed it to the genitourinary syndrome of menopause, because it brings in both the genitourinary stuff, but also kind of, the vaginal stuff.
Makes it impossible for us to pronounce it.
But makes
I
sense.
know.
Makes sense, but yeah.
GSM, we'll just call it GSM.
There you
Yes.
go, GSM, people, when you're looking it up online. And we'll have all of these in the show notes too. We link everything to the show notes. And you've actually
Lovely.
sent us a few reports that were wonderful that we'll
Yes.
also link in
Excellent.
the show notes for
Great.
people to
Great.
check out. The vaginal estrogen cream, would that be daily? Every day they would use it?
It's twice weekly.
Twice weekly. Okay.
Yeah, for the cream, the tablet, and the capsule, which are all inserted into the vagina. Then there's a vaginal ring, and that stays in for 3 months. Usually that doesn't work as well if you've had a hysterectomy because it kind of stays at the top of the vagina near the cervix. But that's a great option for women that forget to do, twice weekly. That's a really weird frequency. And if you're busy and doing other things, the estrogen can be really helpful.
Would you go into the doctor to have a new one put in? Okay. Or is that
You could.
Oh.
I care for a lot of older women with urinary tract infections that use the estrogen, and so they'll come in every 3 months and we'll do that. But many women feel comfortable. It's kind of like inserting a tampon, or if you've used diaphragms in the past. But that's one of the factors that you'll work with your doctor to figure out. Yeah, that makes sense for me, or maybe I'll do like a tablet that has an applicator and I can just insert it.
Dr. Kling, we want to thank you so much. For our listeners, it is so hard to get into a room with an expert who knows so much. And the fact that Dr. Kling took all this time to answer our questions, we truly appreciate it. We value your time and your information. So thank you.
It was my absolute pleasure. Thank you, ladies.
Thank you.